Hello, everyone. This is a session on narcolepsy abstract highlights from AN 2020. I am Maurice Ohayon. I am a physician, biologist. I am a professor of psychiatry and behavioral sciences, director of the Stanford Sleep Epidemiology Research Center at Stanford University. Narcolepsy is a rare disorder characterized by excessive sleepiness and cataplexy episodes. Prevalence is estimated to be around 0.04 in the general population and likely underdiagnosed. Susceptible to comorbidities like depression, anxiety, obesity, autoimmune disease. The pathophysiology is linked to reduced orexin A and B. Treatment focused on neurotransmitter systems believed to interact with orexins, including catecholamine system, sodium phenol, amphetamines, methylphenidate, modafinil, GABA system, sodium oxybate, histamine system, pitolisant, and numerous treatments are presently in development. So what is the AN 2020? AN annual meeting was scheduled for April 25th to May 1st, 2020 in Toronto, Canada. It was canceled due to COVID-19. Abstracts were published in Neurology. So I will go with the first presentation that is reporting about the natural history of narcolepsy. This is a presentation that I did myself on concomitant evolution of treatment and symptoms of narcolepsy in a longitudinal study. 291 narcolepsy patients were interviewed twice, 5 to 7 years apart. It means that the subject at wave 1 are the same than the subject at wave 2. What we found is that hypersomnolence at the first interview for sure was present in 100% of the case. At the second interview, 78.5%, and the chronicity, it means the presence of hypersomnolence at wave 1 and wave 2 was 78.5%. For cataplexy, 87.3% at the first interview, 76.1% at the wave 2, and the chronicity is 96.2%. For the treatment, more interesting, taking narcolepsy medication at wave 1, 71% of the patients were taking narcolepsy medication. At the second interview, 56, chronicity 78.8%, practically no change. CNS stimulants, 49.2% at the first interview, 37% at the second interview, chronicity 52.7%. CNS depressant, it means hypnotic, tranquilizer, 19.1% at first interview, second interview 17%, 67.6% of chronicity. For the antidepressant, 38.6%, second interview 29.6%, and chronicity 58.9%. The antidepressant plus stimulants, the cumulation of the two, 21.2% at the first interview, second interview 16.1%, and chronicity 75.9%. So the conclusion is narcolepsy is a chronic disease that requires long-term multiple treatment in more than 80% of the cases, with a particular accent on antidepressants that are also prescribed chronically for narcolepsy. So we are going now in the section FDA-approved treatments. And the first product that we see is medication is sodium oxybate. This is a presentation done by Emmanuel Mignot The combined data from children in a placebo-controlled trial plus open label extension up to 2 years with a number of patients of 44. In children switching from placebo to sodium oxybate, the improvements in sleep architecture were important arousal night measure. In children remaining on sodium oxybate, sleep architecture remained stable. In placebo-controlled study, treatment emergent adverse events included enuresis, nausea, vomiting, headache, weight loss. In open label extension, these adverse events included upper respiratory tract infection and nasopharyngitis. We have again on sodium oxybate. So this was a placebo-controlled randomized withdrawal study in children to determine if sodium oxybate can reduce cataplexy. In drug-naive patients, cataplexy-free days week changed from 0 at start of the study to 4 by end of the titration phase. During the stable dose phase, cataplexy-free days per week remained similar in the drug-naive patients and those previously taking sodium oxybate. During the withdrawal phase, participants randomized to placebo saw their cataplexy-free days per week drop to 0, while those remaining on sodium oxybate saw no significant change. For the pitolisant, Eric Bauer and collaborator were presenting safety and tolerability of pitolisant in the treatment of adult patients with narcolepsy. This was an open label expanded access program. The number of patients was 623. 88% of these patients were previously used for other narcolepsy medication. 35.2% of the patients discontinued, 16.7% due to adverse events, 12.2% due to lack of efficacy. And you see the number of adverse events and the percentage of patients: headache 10.8%, nausea 7.2%, anxiety 5.9%, and insomnia 5.4%. The next presentation on pitolisant was done by Craig Davis and collaborator. This is a pooled data from 2 placebo-controlled trials, 7 to 8 weeks of treatment. The first post-hoc analysis on 108 patients with Epworth Sleepiness Scale superior to 16. The mean decrease in EES from baseline for the pitolisant group was 6.1. For the placebo group was 2.6. Post-hoc analysis 2, the mean increase in sleep latency from baseline for the pitolisant group 7 minutes, for the placebo group 3.4 minutes. The third post-hoc analysis, 31 patients with more than 15 cataplexy attacks per week. Mean decrease in attacks from baseline for the pitolisant group, 17.9 attacks per week. The placebo group, 2.7 attacks per week. Another presentation on pitolisant by Annika Triller and collaborators, effect of pitolisant on nighttime sleep. Drug known to reduce daytime sleepiness, but does it improve nighttime sleep? 15 patients with narcolepsy type 1 given pitolisant for 6 to 12 months. As you see, the author concluded that real-world data would suggest there is no significant change in sleep architecture in narcolepsy patients treated with pitolisant. Another project, Soriam et al., Nancy Foldvary-Schaeffer, and collaborators. Long-term effect of Soriam et al. On functioning and work productivity in participants with excessive daytime sleepiness associated with narcolepsy. Long-term extension study in patients taking Soriam et al. At 3 dosage for up to 50 weeks. Assessment included functional outcome of sleep questionnaire short version and work productivity and activity impairment questionnaire, specific health problem. The result are the following. The efficacy change from baseline for the FOSQ-10 score, so the mean change, is 3.7. For the WPAI-SHP, you have the activity impairment outside work, so an improvement of 26.7%. Impairment while working, you have an improvement of 29.5%. And for the overall work impairment due to problem, an improvement of 29.5%. As you see, the adverse events are on the second column. Another presentation on Soriam et al., clinically relevant effect of Soriam et al. On excessive daytime sleepiness. A post-hoc analysis comparing placebo to Soriam et al. 3 doses, 75, 150, 300 milligrams per day. So the percentage of ESS score less than 10 for the placebo group was 15.5. For the Soriam et al. Group, 75 milligram dosage, 30.5%. For the Soriam et al. Group, 150 milligram group, you have 14%. For the Soriam et al. Group with 300 milligram dosage, 49.2. Adverse events, mild to moderate, were concerning the following symptoms: headache, nausea, decreased appetite, nasopharyngitis, dry mouth, and anxiety. With treatment option in development, we have a project that is a FT218, a once nightly sodium oxybate formulation for the treatment of narcolepsy. Presentation by Jordan Dubois and collaborator, pilot pharmacokinetic study in 16 healthy volunteers to compare pharmacokinetics of once nightly FT218 with twice nightly sodium oxybate. Study observed favorable PK profile for sustained efficacy similar to twice nightly sodium oxybate. A second presentation by David Seiden and collaborators, pharmacokinetics, adverse events relationship for FT218, 129 volunteers given 6 different doses. Adverse events, as expected, and mostly occurred close to Tmax during the Cmax period. Pharmacokinetics and dose proportionality of FT218, 20 healthy volunteers given 3 doses of FT218, PK profiles similar for all 3 doses. Another presentation by David Seiden and collaborator, pharmacokinetics of once nightly sodium oxybate FT218, food effect and relative bioavailability compared to twice nightly sodium oxybate. In the fed state, FT218 had a longer Tmax, lower Cmax, and decreased AUC compared to person given FT218. Also in treatment option in development, GZP258, Nancy Foldvary-Schaeffer and collaborator, efficacy and safety of GZP258 in phase 3, placebo-controlled, double-blind, randomized withdrawal study in adults with narcolepsy with cataplexy. GZP258 is a novel oxybate product, less sodium. FDA review largely based on phase 3 study. 2 abstracts focus on that study published for AN 2020. Trial design was 201 adults with narcolepsy and catalepsy. Initially, patients received titrating doses of GZP258. 134 patients then randomized to placebo or GZP258 for a period of 2 weeks. The results: median weekly cataplexy attacks in the group GZP258 to placebo, 2.35. In the group GZP258 continued, 0. Highly significant. Median ES scores, GZP258 placebo, 2.0. And in the group GZP258 continued, 0. Highly significant for sure. Percentage of patients who thought narcolepsy worsened. In the group GZP258 to placebo, 44.6%. And in the group GZP258 continued, 4.3%. Also highly significant. The percentage of clinicians who thought narcolepsy worsened. GZP258 to placebo, 60%. And in the group GZP258 continued, 5.9, and the p-value is highly significant. For the adverse events, headaches at 20.4%, nausea at 12.9%, and dizziness at 10.4%. Always in the treatment option in development, Michael Torpy and al. Looked at cataplexy rates during open label phase of study when patients were being tapered off other treatment. So the results are the following. At week 1, in the group sodium oxybate, that is 41 patient, 2.0. In the group sodium oxybate, other anti-cataplectic, and 14, 0.6. In the third group, other anti-cataplectic, n equal 21, 3.5. On the fourth group, anti-cataplectic naive, where the patient were 58, the result is 5.8. End of open label 12-week titration phase, sodium oxybate 1.0, sodium oxybate plus other anti-cataplectic 2.2, other anti-cataplectic 2.3, and in the group anti-cataplectic naive 2.0. End of open label 2-week steady dose phase, sodium oxybate 1.0, group sodium oxybate plus other anti-cataplectic 2.0, group other anti-cataplectic 2.0, and last group anti-cataplectic naive 0.9. So in conclusion, narcolepsy is a rare chronic disease with multiple implications in the quality of life of the patients. We are all searching for new treatment, new possibility for our patients. This session is showing us how much the field is active to find new treatment. We see new opportunity, and many projects are presently in development. We see that the number of treatment approved by the FDA is increasing, and that they show their efficacy. Newer treatments are coming, and this is the promise for the future. I want to take the opportunity to thank AN for their effort to publish and promote the results of this study and show the progress done in this field.